First adjustment for today is a supine index pillar push. This is good anywhere in the cervical spine, really. We'll even adapt this to the upper cervical region. Index contact, articulate pillar, patient supine. The headpiece is going to be positioned so the cervical spine is neutral. I'll demonstrate this in a C3, C4, C5 level. Tissue pull is going to be it depends on what you want to accomplish. You can use this move for rotation, you can use it for lateral flexion. Generally speaking, if you're using the move for rotation, you're taking a posterior to anterior tissue pull. If you're utilizing the move for lateral flexion, you're taking a front to back tissue pull. If, however, you're combining the two, which you can do as well, it really doesn't matter what the tissue pull is, as long as the preload is correct. I'm seated, my patient's supine. The doctor can also kneel or stand if they want to. The auxiliary hand, I'm just going to have you turn your head so the camera can see this. The auxiliary hand goes over the side of the head. Right? If you want to have perfect placement every time, put the ear of the patient right here. You'll have maximum control of their head, and think of your hand as one of the loop of Velcro and the partner on the other side, and just loop in there. No one's ear has ever been injured from this position. All right. Contact, let's say it's C3, find the C2 spinous. And what you want to do with your contact for this is to really have control of the head. Right? So once you have your contacts in place, you want to make sure that you actually have the head. I like to leave the head on the table. If I wanted to do this just for rotation, I would, with both hands, my contacts in place, I would rotate the head. Camera can see that just fine. I would actually kind of come in a bit like this to do the adjustment, but I'm sitting back a little bit so the camera can see the contact. When I'm actually doing this move, I would actually come in, the camera can still see that, come in so that I'm opposite the area that I'm actually adjusting. So my center is opposite the adjustment. So that would be for rotation, index pillar push for rotation. If I wanted to do this for lateral flexion, everything's the same. I'm going to grasp the head the same way, but instead of rotating, I'm just going to impart that lateral flexion to it. All right? Again, I'm going to kind of slide in so that I'm opposite the contact, and there's the same adjustment for lateral flexion. Now, what I usually do when I perform this is combine both. I'll add them both together. So if you're going to do lateral flexion and rotation with an index pillar push, what you'll do is you'll laterally flex first, then rotate, but don't let up on the lateral flexion. Because if you do, you'll just lose it. Right? So laterally flex first, then rotate with whatever the patient's cervical spine will give you, and then make sure you're in place. Make sure you're in place to deliver that adjustment. All right? So that's our index pillar push. We can also do this. This would be considered an assisted type of an adjustment because we're thrusting with the direction that we're moving in, right? So I'm creating left rotation and I'm thrusting P to A on the right, creating left rotation. I want to do this as an assisted adjustment. There's an adjustment that's called a supine resisted index spinous push for rotation. Index spinous push, and here's how it works. It's very similar to the contact that I'd use for lateral flexion for the index pillar that I was just demonstrating. However, instead of just stopping on the pillar, I'm going to take the contact all the way down to the spinous process. So I'm up against the spinous process. All right? Pushing the spine, the vertebral body that I'm on to the right. Would everyone agree that I'm pushing that to the right if I'm on the spinous? Right body rotation. So I have a very firm contact for right body rotation. Then what I'll do is I'll take my auxiliary hand, make my contact to have great control of the head with both my hands. But with that digital contact against the spinous, I rotate my patient all the way to the left. All right? So with that contact in place, I've preloaded him into left rotation. But when I thrust on, in this case, C3, right? C3 is moving to the right. So my thrust is resisting the preload that I created with my setup. And that's what makes it resisted. So So again, the tip of my contact right here is coming up against this C, whatever level you want, C3, C4, C5. We'll come down a level. Let's make this C4. I'm pushing C4 into right rotation. Tuck your chin a little bit. But I rotate my patient all the way in the opposite direction. So when I thrust, I'm creating right rotation of C4 on C3, right? Whenever you're doing a resisted type of adjustment, you're always adjusting from below. Most of the adjusting we do is from above. So that's a little bit different, just a little bit different flavor for an adjustment. Very effective because you're really creating counter rotation in the middle of the cervical spine. So it works very, very well. Let's look at the index pillar push for an A to P rotation restriction, A to P rotation restriction. We did this motion palpation last week. So index, pillar, but now I'm coming in from the front, right? Headpiece is going to be relatively neutral, right? My contact comes in, let's say this was a C6, C7, A to P restriction. So I come in, again, on the anterior portion of that articular pillar. Right? You want to be careful. You don't want to catch the tips of the TPs. My other hand supporting on the opposite side. Headpiece is elevated and the chin patient's flexed. My other hand supports the head neck on the opposite side. Just take that hand, wrap it around. My forearm is on the head, the forehead, and what I'll do is I'll bring everything over to the side that I'm on. Hope the camera can see that. All right. So there's my A to P setup right there. Tuck your chin for me a little bit, and if I wanted to actually do this adjustment, I would just follow through HVLA for that A to P index pillar push, A to P restriction. You can also do this with the thumb, right? So for the thumb contact, remember we palpated like this, right? Grab that thumb. Use the thumb to grab the anterolateral articular pillar, right? Hold on to the patient's head with both hands. Rotate it to the same side, right? Is it okay to actually demo this? Mm-hmm. Right. So there's my contact coming down on the articular pillar. My hand is, my forearm is on the forehead. Bring this around. And then the adjustment is HVLA, A to P on the right. That would be for an A to P restriction on the right side. Okay? We can also do a index pillar pull, supine pull, right? So for that adjustment, I'm going to be on the opposite side. This is actually one of my favorite moves after my, if a P to A pillar push is not effective, this is a very nice move to follow up with, right? So it's the middle finger, right? And again, this move can be done for rotation, lateral flexion, or a combination of both, right? So the contact is the middle finger on the articular pillar, right? Headpiece is going to provide some neutrality for the cervical spine. The other hand is going to come in along the side of the head, right? Same principle applied. Just put the ear right in the center. And again, what you want to have is good control of the patient's head, right? I wouldn't do this with a paper. I'm showing that I have his head in my hands. So now if I wanted to create rotation, there's my contact. Nice gentle pull up on the articular pillar, anywhere in the cervical spine. Just rotate the patient towards me. I've got control of their head and my contact's in place. For rotation, the thrust would just be an HVLA towards me, right? For lateral flexion, I'm not going to impart any rotation, same contact, it doesn't change. I'll just push the patient away from me. I'll use that contact as a fulcrum, and it's going to be a thrust equal and opposite through both hands for the lateral flexion aspect of this. For the combination of the two, I'm going to laterally flex first, just like I did the index pillar push, maintain that lateral flexion, and start to turn that patient's head towards me like that. You'll notice the head won't go very far into rotation once you establish lateral flexion. My patient's head is always resting on the table. I never have to pick the weight of the head up. that allows me to relax a lot more. And again, it's just an HVLA delivery with a middle finger pillar contact. Okay. So for the middle finger pillar pull, right, in the seated position. Rotation, lateral flexion, or combine the two. You can do this anywhere from C1 all the way down to C7. Patients in a neutral posture. Just make that nice, gentle pull onto the articular pillar. You can step in close with permission if you need to, or you can stay a little bit to the side. Just bring this leg out. All right. But again, the key is to have the patient's head. I'm exaggerating a little bit, but I want to have their head. He feels like I have control of him. He can totally relax in my hands. If I want to create rotation here, I simply rotate him towards me like he's going to look at me, right? I have both hands holding him firmly, and I can follow through with my adjustment from there. If I wanted to create lateral flexion, I can simply bend him over the contact, right? And it's going to be a thrust towards me and a push away with the auxiliary hand. What I usually do with this adjustment is combine the two, right? So again, it's going to be lateral flexion. The other hand, the center of the hand goes right over the center of the head, right over the ear. Just watch out for the eye. That gives you maximum control. Do me a favor and swing all the way around. Keep swinging, keep swinging. I just want the camera to see it. Keep going, keep going. Just want the camera to see that contact for a moment. All right, so it's right over the head. Spread out wide. I want to maximize the area on my hand. Now come back to where you were. All right, perfect. So again, lateral flexion. And again, the cervical spine will not rotate much after that. So once I'm in this position, I'm good to go. I can relax. I'm very, very relaxed, and I can just add my HVLA from there. And those are the seated variations of this. I'm going to show you one more A to P variation. It's the last adjustment I would do. Actually, I want to show you two more. Sorry, I forgot two more. There's two more A to P adjustments I want to show you seated. One is, turn this way a little bit. One is a hypothenar articular pillar contact coming right up onto the anterolateral portion of the articular pillar. So coming in just like that, holding the head with both hands, rotate to create that A to P movement. You can laterally flex away a little bit. My other hand's on the opposite side supporting the head and neck, and the thrust is going to be in that anterior to posterior direction. That would be my least favorite choice of all those adjustments. This one that I'm going to show you now is one of my favorites. It involves the same type of setup as the assessment. So remember, for the assessment, we took our digits, we placed it in the anterolateral space, we flexed the head over the contact. This is a little review of last week. We rotated it and we gently pulled back to assess that A to P. Right? So the adjustment's almost the same. Take the index contact, very soft, and just lay it right over the area you want to create the fulcrum at. Nice and soft. Flex the patient over it. Laterally bend them over it. I already adjusted him in this direction, so I'm not going to thrust again. Again, the other hand makes a maximum surface area contact on the other side. Doctor's nice and relaxed. The patient's head is just hanging down and over and rotated to the same side, and it's an HVLA thrust through both hands. It's very important with this delivery that you at least 50-50 it. You don't want to go more than 50% on this hand because you're in a delicate area on the side of the neck. So 60-40 the other way is even acceptable. You're creating a fulcrum over the contact, and that's an effective A to P adjustment as well. So when you use these A to P adjustments, when you find mid-cervical restrictions, you should always check for them. Mid-cervical spine is often has too much extension. Forward head carriage rather. There's too much anteriolisthesis of those middle segments. This type of adjustment brings everything back using flexion. This next adjustment is a prone index pillar push. Again, this adjustment can be done for pure rotation, it can be done for lateral flexion, or it can be done for a combination of the two. It can be done ipsilaterally or contralaterally. I prefer ipsilateral only because I don't have to bend over as much. These adjustments work best with patients who are kind of moderately stiff, not too flexible. The real hyper-flexible patients, you're much better off with a supine type of an adjustment because you'll have more control of getting the patient to the position that you need to get them in. So for this adjustment, obviously our patient's prone. It's an index contact right along the articular pillar. Use a very soft part of your hand, very gentle contact. If you're going to do pure rotation, just ask the patient to lift their head up and turn it all the way to the left and just follow it around. From there, step in, contact the side of the head, traction down and cephalward, and just add your HVLA in from there. All right, come back to the center. If you're doing just lateral flexion, you can alter your tissue pull a little bit so you're coming a little bit from front to back. You can just take your hand on the side of the head, bring the head into lateral flexion, perhaps lower the headpiece, bring the head into lateral flexion till you feel like you've isolated that level. And again, the thrust is going to be from, in this case, from right to left. Again, you probably can see in the camera, and those watching can see there is a little bit of rotation anyway, all right? If you really wanted to purposely combine the two, then by all means rotate and laterally flex, load it up with those two directions in place, and the adjustment's actually done quite gently just by adding the HVLA in with the two hands. Just go over those variations for the prone index pillar push. I showed it before from the same side. This can also be performed from the opposite side. Pull it over a little bit. So, I'm going to actually push this forward here. There we go. Okay. Okay, so basically, I want you to see the contact again. It's just a very soft contact right on the articular pillar. If we were doing this for pure rotation, you're down close. The headpiece is down a little bit so we don't get any extension when they lift their head up. You'll instruct your patient to totally lift the head up and turn it, and your contact follows the segmental contact point around. You traction down on the head and thrust at the same time. HVLA through both hands. Come back in the center for a moment. This can also be done from the superior. Again, nice soft contact on the articular pillar. Bring the head over. I'm going to show this one with coupled rotation, lateral flexion. Bring the head over the contact. If you need to, have the patient help you to bring the head over. Let's bring this arm down, tuck it into your side so we can just see this a little bit better. All right. And there's the balance of the preload right there. The leg on the side of my contact is always back. That's what gives me my power. Right? And there's the setup for the prone index pillar from the superior.